who is a 60-year-old lady, has history of pituitary macroadenoma, hypertension, and DM. She has history of incomplete colonoscopy in May this year due to looping. That's why we arranged a CT colonography screening for her in August, which shows an incidental finding of 3.7 cm lobulated cystic lesion at the pancreatic tail. The pancreatic duct is not dilated. There are also no enhancing mural nodules. Otherwise, she doesn't have any abdominal pain, jaundice, nor weight loss. This is her CT imaging, which shows you the pancreatic tail cystic lesion. So today we'll perform EUS plus or minus FNA to lesion with confocal endomicroscopy and through the needle biopsy. And if needed, we'll perform alcohol ablation as well.
Hello.
Hello,
Are you with us?
Hi. How are you?
Welcome to our
Good morning.
endosonal room. We are welcoming all of you. I am supervised by Dr. Uzma Siddiqui. She is helping this procedure and also educating me.
I was saying Professor Seoul was very impressed with the confocal yesterday, so he's going to do his first and maybe his last confocal case today.
I inserted my echo endoscope into the mid-body of the stomach and touching the posterior side. Now I am tracing the splenic vessel and the pancreas parenchyma and also main pancreatic duct. This is main pancreatic duct. From this position, if I rotate my scope clockwise, then I will go to the body and tail area of the pancreas like this, little by little. During EUS, we never require jerky movement. Slow and gentle movement is good enough to see the structure and the parenchyma of the pancreas. Here, near the tail of the pancreas, we can appreciate a rather large cystic lesion here. And if we see this kind of cystic lesion, as Uzma did yesterday, we need to consider the demographic data. This is female 60-year-old. Generally, female has more tendency to have a mucinous lesion or serous lesion. And for men, IPMN possibility is high. And also, we need to check the shape of the cyst. There is some septations inside the cyst. Can you appreciate that?
Yes, we can see that.
Are you with us?
Can you hear us?
Although
Hello?
it's very thin.
Hello?
Yeah. Can you see that? Hear us?
Yes. Yeah.
The septum is very thin.
And also one other characteristic, this lesion is located near the tail. So
Yes.
a female with a tail lesion would make you think about a mucinous cystic neoplasm initially on the differential.
Yes. But if you judge just by shape of this lesion has several septations. So it is oligolocular cyst. And if you look at the wall or septa of this lesion, there is no definitive mural nodule suggesting malignancy. And this area, in some views, looks like a crowded septum. And when you see serous cystic lesion, sometimes we can appreciate the central stellate calcification. If there is a lot of septations here, this lesion may look like a central scar. But at this stage, I think by morphology, I cannot be sure completely. It can be either mucinous cystic neoplasm or oligolocular serous cystic tumor. And I am, before the camera comes to this room, I already checked the communication between main pancreatic duct and this cystic lesion, but it was difficult to show it clearly. So I'm not suspecting any definitive communication with MPD with this cystic lesion. Then what is your differential, Uzma?
The exact same. I would say mucinous cystic neoplasm first, given the female gender tail location. But because there was the possibility of a central scar there, serous cyst adenoma would be my next thought.
Yeah. And
but that was our discussion actually before we went live. Is obviously your spending extra money using advanced imaging tools. So you try to use them in lesions where, again, you may not have a definitive diagnosis. So
Yeah.
we were going to try to do confocal again. The patient received IV fluorescein about 5-6 minutes ago, which is usually optimal timing for getting good uptake within the cells. We preloaded the confocal probe again into a 19-gauge Olympus needle.
Yeah. Before that, I want to show you one more trick for the differential diagnosis of the cystic lesion of the pancreas. Nowadays, they have e-flow function, and if you use the e-flow, then we can detect very minute blood flow inside the cyst or cyst wall. So if you use this one, I think you can appreciate some septal flow. Inside the septum, we can you can see that there are some microvessels.
Which would make you think more serous cyst
Yeah.
adenoma.
Generally, serous cystic lesion shows this kind of feature, but mucinous lesion does not show very strong Doppler signal inside the septum. So, based on this e-flow finding, I am more suspicious of serous lesion. But this is just one criteria, but we cannot be sure. So, overall, I would think this cysts fall into the category of indeterminate cyst.
But I think this is a great opportunity to get more information, because if we thought a mucinous cystic lesion, you'd recommend surgery.
Yeah.
Versus if it's a benign serous cyst adenoma, she has no symptoms, you could just observe.
So I'm going to puncture this cyst and try to look at the confocal
Try
by the
very
education
hard.
of Uzma, and I will try to aspirate the cyst fluid, and we will send it for CEA and amylase, possibly cytology analysis for this case.
Now, there has been, again, published studies noticing a superficial vascular network, again, kind of mimicking those multiple blood vessels that we saw in the e-flow. As far as confocal imaging for mucinous cystic neoplasms, it's not that well established, and I would say there's just been a couple descriptions of finding a denuded epithelial lining in the cyst, and what they call horizontal epithelial bands for a mucinous cystic
Okay.
neoplasm. But again,
Now we are touching the wall of the cyst.
we're going to
We are pushing the probe a little bit outside of the needle, and we are going to look at the cyst wall.
all right. So hopefully we'll see a superficial vascular network.
And that part will be explained by Uzma. I've never experienced on confocal. Confocal is not available in our hospital.
If you could maybe try to move a little bit along the wall, that might be helpful.
Can you show us the
Now, let's
confocal
just-
images?
Oops. We'll try to go back and see.
Mhm.
We are in this one view. I don't know if you can appreciate. There appears to be bright white that could indicate multiple blood vessels and perhaps a superficial vascular network. Again, it records images very fast, 12 frames per second. So you do have a cine function on the system where you can go back and look at your images. I'm not seeing any obvious epithelial lining, though, that would indicate an IPMN. There's no finger-like papillary projections.
So even
So
after
when we
confocal,
see
we cannot
papillary
get
projection.
clear diagnosis.
So there are 4 patterns. When you see the papillary projection is the IPMN.
Correct.
If you are seeing the
Here's-
white,
Here's some vascular
the
structures.
white dot is pseudocyst. And what's the for serous lesion?
Serous lesions are superficial vascular network. Oops. And we have seen a lot of vascularity in here. There's a vessel in the middle of the screen. I think it's transmitting very bright, but I don't know if you can make out. There's almost like a V shape, and there's blood vessels there. But again, the main issue with confocal, especially when you have a large cyst, is that there's variability along the cyst wall lining, and so depending on where your needle and your probe are located, that may alter or impact what you're seeing. So most of the studies show very high specificities for the papillary projections or the superficial vascular network. Actually, there again, you're seeing multiple blood vessels. So we've gotten quite a few views now where I'm seeing numerous blood vessels that could suggest a serous cyst adenoma in a superficial vascular network. More so than what we saw yesterday. But again, sensitivity for this technique or technology is about 50%. But I don't know, Professor Say, are you convinced? Serous cyst adenoma? Maybe.
I don't know the confocal findings. It's up to you. Now I'm going to remove the confocal probe and I'm going to aspirate the cystic fluid for analysis. Okay?
Yeah,
I want to get the
that
EUS
was,
image now.
One of the questions that why there was a need for preloading Cervicio probe.
Sorry, Norio, what did you say?
Why did you preload the Cervicio? Because it's protected, or
Yeah, it's only 0.85 millimeters. It's very easily damaged. And in the initial pilot study using this particular probe that we published in 2011, we found that preloading it prevented it from getting damaged. And the probe can be used about 10 times, so you want to try to get your full money's worth out of it.
This part is quite tricky. As we aspirate the cystic fluid, the cyst size becomes small. And if there is no space, then we need to change.
And are you seeing the fluid that's being aspirated?
Yeah. This looks like a serious one. Huh? Does not look like mucinous sticky one.
No, it looks
okay, inject.
Golden yellow.
I cannot have enough time to explain the technique of ethanol lavage here. Yes. How much did you aspirate?
How much alcohol you are injecting?
Yes.
얼마?
Can you show us the fluid?
The fluid looks kind of golden colored.
Yeah.
And now
brown.
His assistant is injecting alcohol for the ablation.
Yes.
So any tricks that
During
you would like to tell
ethanol
us?
injection, the patient may feel pain. So generally, demerol, petidine injection is generally required. Yeah. We aspirated 13 cc of ethanol. Now we are injecting same amount of ethanol into the cyst, and we are going to reaspirate it.
I noticed you didn't aspirate the cyst completely, so you only did it partially prior to your initial alcohol infusion.
It's because if the cyst collapses, then the needle tip, we cannot guarantee the needle tip is still inside the cyst. Because of that, I try to expand the cystic cavity again. And after initial aspiration, we will try, because we are doing this lavage several times. Here.
So the sequence is you aspirate half of the content of the cyst.
Most of the content, firstly. As much as we can without causing any problem.
And again, since you didn't see any communication with the pancreatic duct, you're not really worried about pancreatitis?
Stop.
So, Dongwen, so
Yes,
we
we are
have
not very much worried about pancreatitis in this case. And the procedure should be quick. If you spend more time, there is a risk of leakage and the development of pancreatitis. So better to focus on this procedure. And this is second time injection.
So we have a question from
Dong Wong,
Yes.
if the balance of evidence is that this is a serous cystadenoma, why are we ablating it with alcohol? What is
We are
the
not
risk benefit?
completely sure.
Well, yeah. He's not convinced the confocal was that
we
useful.
are not completely sure this is serious one. The only way is resect it and see the pathology. But that's too much for this case. So, yes, this is second time lavage, aspirate.
And then
So would it be not better to wait for the results of the cyst aspirate rather than just assume that this is mucinous? The fluid itself did not look mucinous. It did not have a string sign. The the evidence from the confocal was weighted toward a serous cystadenoma. So it seems like you've got very little evidence to suggest that it's mucinous, and yet
We are
you're
creating
treating it
evidence.
as if it's that.
We are creating evidence. No, any kind of new therapy comes from evidence. That's yes, okay. I want to just focus on the procedure. After the procedure, we can discuss. Yeah, inject. The most important thing is keep the needle tip inside the cystic cavity. That's very important. Otherwise, you can inject ethanol outside of the cyst, and it will create peritonitis or pancreatitis. Yeah.
It's okay. Dongwen, you have something to show us?
Hello? Yes, I finished 3 times of lavage already. Now, can you see my EUS image?
Yes, we have US image.
Yeah. Previously, on this part, we were able to see cystic lesion, but we cannot see very clearly the large cyst here because we already aspirated most of the cystic fluid. And this is the first aspirate. If you look at the color of this is a little bit brownish one. And if I rotate like this, I cannot see. This is almost fluid-like. So I am suspecting by the viscosity-wise, this is more likely serous one. But yes, you can do 2 times of approach. See the result, cystic fluid analysis result, and reschedule the treatment in another day. But that's quite cumbersome for patients, so I just treated one. And this is first ethanol injection and re-aspirate one. If you see this, the bottom here, you can see a lot of debris is inside. Can you appreciate that?
We can see
In the bottom.
Yes.
Or Uzma, can you show? Yeah. In the bottom.
You can see.
Yeah. In the bottom here, there is a lot of debris. That means the ethanol actually caused epithelial lining ablation. So this quamated material is collected like this. If you repeat this, then the color will become much clearer. So I think in this case, anyway, the cystic lesion will disappear. I guess the probability of complete resolution on this case is very high. Is there any question or comment?
When will you repeat imaging?
Repeat images. This patient can be discharged tomorrow, and 6 months later, 1 year later, if you see complete resolution at 1 year period, then you can do surveillance maybe 2 years later. I think that's enough for this case. Yes, we are thinking that serous cystic adenoma, if it is serious one, we don't need to treat. But my thought is different. Even though it is serious one, it shows progressive size increase, then it will actually be a concern for patients. So if the treatment method is not surgery and simple and safe enough and effective enough, my thought is better to treat that one, like colon polypectomy.
Okay.
Any
So,
other?
thank you.
Yes. Thank you.
May I ask one question about the safety issue? As
We
you
can't hear you.
mentioned-
Hello?
Can you hear me?
Yes, now we can.
Great. So about the safety issue, I mean, indication and the efficacy, there's a lot of question about that. But for the safety, do you confirm connection with the pancreas duct in some way beforehand, or just the endoscopy image is on?
It depends. Yes, that's a good point. If the lesion is located in the head portion, the evaluation of pancreatic duct communication is very important, because if we damage the main pancreatic duct by this method, then the body and tail area, majority of the pancreatic parenchyma will be affected. But in this case, it is located far upside of the tail, so I'm not worried about. Even though I may damage some of the branch duct, I'm not very much concerned on that. But if the lesion is located in the head or neck area, it's better to prove it when there is clear communication with the US, you can believe it. If there is no clear communication, we also need to check MRCP finding and also CT finding. If you are suspicious, then better to do ERCP and get the pancreatogram. If there is communication, then you can insert pancreatic stent to prevent serious problem.
Last question. In your
Okay, so thank you, Dongwen.